privilege of working at the Massachusetts Association for Mental Health. I'm happy to be here this evening with all of you, and really excited to understand that your organization has a mental health awareness initiative, and that you're focused particularly on the importance of promoting awareness and improving access to care for people in minority communities. I want to talk a little bit about the Massachusetts Association for Mental Health. We predate most other behavioral health stakeholder organizations, the professional societies, NAMI and others. We were founded back in 1913 as the Massachusetts Society of Mental Hygiene. We were an early state in this movement, founded by a man named Clifford Whittington Beers. Mr. Beers, while a student at Yale University in the late 1800s, suffered from depression and alcoholism and was hospitalized at what's now Connecticut Valley State Hospital. He left that hospital and recovered from that experience and from his conditions, and went on to found our organization and one in Connecticut that became the prototypes for mental health associations around the country. And from early on, the founding principles of our organization were, I think, quite progressive. It was to work on the conservation of mental health, protecting people's mental health and well-being, to help to raise the standard of care for people who not only had these conditions, but were at risk for developing them. He had that insight that there was risk and that risk could be managed. And finally, to familiarize the public with the care and treatment that was available, including actually an early focus on community-based treatment, not just institutional treatment. So we are still at it because we have not achieved the original visions and goals. This is a long work in progress. But today, MAMH's vision and mission does not stray far from the original founding principles. We do envision a day when everybody in Massachusetts has access to social and economic opportunities that are key to protecting their health and promoting their resilience. Basically protecting people's mental health, which is vulnerable to economic and social conditions. We've seen this during the economic downturn of 2008. We've seen it again in the COVID crisis, that people's economics, work, therefore their housing security, food security, and other related issues, the disruption in those creates stress that is difficult, and in some people creates depression, anxiety, and more serious conditions. And if we are to be effective at preventing preventable illness, these preventable conditions, we have to make investments in stabilizing our economy and stabilizing opportunities for education and work, and various supports for recovery for people who do acquire these conditions. Therefore, we've had as our mission advancing not only mental health and well-being, but also trying to promote actively prevention, to see that there are resources available for early intervention, because the sooner conditions are treated, the more treatable they are, and pushing for effective treatment, and particularly research here in the Commonwealth and across the country that could benefit us and help us to understand better how to address the social, emotional, and mental health challenges that face all of us. By doing that, we hope to eliminate stigma, but more importantly, the discrimination that emanates from stigma. And this is something, of course, of great concern to minority communities who already face discrimination and disparities. And when it comes to accessing mental health care, behavioral health care, they face additional barriers and discrimination. And we know how important it is to try to address these discriminations And MAMH has really dedicated itself over the years to efforts to combat these discriminations so that the people for whom we advocate have better access to social, economic, and political inclusion, and really are full participants in all aspects of community life. So we have several goals that we map out and actions we take to try to achieve our mission and realize the vision. First is that we work to be a change agent, trying to address the conditions that are undercutting people's mental health and well-being, that are creating barriers to people accessing care. We very much do that by disseminating knowledge about these conditions, trying to educate the general public, but also targeting policymakers who hold the levers of change in their hands often. We try to address inclusion and ensure access to services. So we undertake a number of initiatives to expand access to care, whether that is a more robust benefits for behavioral health care, more types of covered services, but also removing financial barriers and insurance barriers to using care, working to help develop the workforce so that there is an adequate supply of clinicians and other professionals to provide care and treatment. And finally, we act to educate and then mobilize and advocate. So I'll talk more about that. We have a number of strategies we employ as an organization to try to reach the goals. We serve as a neutral convener of all kinds of stakeholders. Now, by stakeholders, I mean people who need these services. Some people refer to them as individuals with lived experience of these conditions, or consumers. We convene family members and other concerned individuals, friends, colleagues. We're working with the business community. We work with schools because business is where adults are during the day and schools is where kids are during the day. We consider them all stakeholders in this. We work with providers. And we invite policymakers and foundations and other philanthropists who are interested in this work to the table, trying to bring everyone together to build consensus on solutions to problems, particularly problems of access, and move ahead based on that consensus to make change happen. We partner with players who are essential to making change happen. In Massachusetts, there's a long tradition of the philanthropic community making the investments that allow us to demonstrate innovation. It has often not been government that, probably not just here, but elsewhere in the United States, it's often not been government that was the base of innovation. Although government at the federal level has often financed the very important research that leads to innovation in the healthcare field. But here in the state, when we're looking at programmatic innovation in particular, and in some cases policy innovation, it's been foundations that finance the initial effort. Once that effort is undertaken and the case is proven, we've been very successful here in getting government to the table to adopt changes and make new policies and implement new programs. Providers are essential. The people who are offering care to those in need of service or who are deploying prevention services. Consumers themselves, people who use the services or might in the future use the services, their voice is critical to guide policymaking, to help to identify unmet needs, and to be voices for change. And then academic research. We are fortunate here in Massachusetts that we are rich in university-based research, and a lot of innovation and clinical developments over the years have emanated from Massachusetts. And We collaborate with academic researchers across the country because not everything happens here, although sometimes we in Massachusetts like to think if it didn't happen here, it's not worth doing. I see people laughing, they understand this, but the truth is there are wonderful ideas and extraordinary research happening all over the country, so we make a point of working with people across the country, not just here in Massachusetts, to try to advance our cause. So we ourselves conduct and promote policy research and innovation demonstrations. I'll talk a little bit more about that later. So we work to expand awareness across sectors. As I mentioned before, we work with the business community, we work with schools, we work with a range of organizations that may touch the lives of people who have these conditions, people who are involved in housing, people in the justice system, etc. And we try to serve as subject matter experts and really generate knowledge and disseminate knowledge that will help people to become more aware, to deepen their understanding about the needs of people who are at risk for or have and live with behavioral health conditions, about the most effective interventions to support their recovery. And our advocacy is, and we are known for, having data-driven and fact-based advocacy. And we do target our efforts intentionally to each of the three, excuse me, each of the three branches of government. So we work with the executive branch. They are the bureaucracies that run the agencies that are mandated to serve people. We work closely with the legislature to make change happen, and we are blessed in this state with some wonderful legislators who are champions of people with these conditions or at risk for these conditions. And we work with the courts because they play an important role, both in establishing and affirming the rights that people have and in dealing with issues related to the overrepresentation of people with behavioral health conditions in the criminal legal system. So I want to give a few examples of how we serve as an effective change agent, which is our first goal. We focus a lot on system reforms, how services are delivered in the mental health and substance use arena, but also reforms in the criminal legal system, because too often people in a crisis end up with the police responding. Behavioral health conditions, I think you all know, it's the only type of health condition where if you call 911, you will not necessarily have an ambulance arrive at your destination or the place where you've called for help. You may well have a police cruiser. And you will almost always, even if you get an ambulance, have a police cruiser. The police do not come out except as an ancillary presence if you call saying you have chest pain. So there is a gross discrimination affecting people with these conditions in this Commonwealth and in many others, around many other states in the country, that their health condition gets a public safety response rather than a public health response. We are working to change that. We're working on affordable housing because people who are homeless, and particularly those people who are chronically homeless, which means you are continuously homeless for 365 days or longer. That's the federal government definition. For those people, 90+% of them are people with co-occurring mental health and substance use conditions. So I'm just going to give a few examples here. In Massachusetts, some of you may have heard of the Executive Office of Health and Human Services, that is the bureaucratic structure over the departments of mental health and public health and the Medicaid programs. They have a new roadmap for behavioral health reform, and we've been very active in trying to support the implementation of that reform. Particularly, it has a new front door to the behavioral health system. By the way, I started my career in Massachusetts in the 1970s, and I was the Department of Mental Health Area Director for what was called in those days the Med Beaverbrook area. So Belmont, Watertown, and Waltham were among my cities and towns. And Back then, we actually did answer the phone 24 hours a day, 7 days a week, and worked with all the hospitals and worked with the police. But over the years, that fell apart. And today, it's the police that answer the phone 24/7. So now, under this new roadmap, there is a 1-800 number, statewide number for a behavioral health helpline. And if you call that number, a trained call taker who's supervised by a mental health clinician will be answering the phone and will be able to assess what your needs are and either connect you in a crisis immediately to a mobile crisis intervention team that's located in the geographic area where you live, or connect you for urgent care, which is a novel thing in mental health. For every other health condition, you can drop in on almost any corner of the Commonwealth to an urgent care center. Now we have behavioral health urgent care in over 60 sites around the state. They have to see known clients within 24 hours and new clients within 48 hours. So we've been advocating for these kinds of changes to make the system more accessible. We also worked with other stakeholders to pass a mental health omnibus law last year that includes provisions for the training and of professionals to address our workforce crisis, including loan forgiveness and scholarships, targeted training actually for minority providers, among other things. And then a lot of work in that bill to enforce the national and state parity laws, which means that insurers cannot discriminate against people who need to use mental health or substance use treatment services. By the way, these laws have been on the books since 2000 in Massachusetts and 2008 at the federal government level, but insurance companies continue to deny care in a discriminatory way. And this bill would penalize them much more severely than they have been in the past for denying care inappropriately. So again, just a couple of examples. And then we advocate for the state budget. Why? Because without the money, you can't do the many things we'd like to see happen. And we particularly focus on investments that lower the cost of care to the people using care, that increase affordable housing and subsidized housing for people who need it, and that target children and families who are at high risk and don't have the resources otherwise to access care. I'm going to move through this because this is more detail. We have a concept at MAMH about change, which has to do with what we call the policy change cycle, which starts with identifying a problem and then defining the policies that could help to solve that problem, and then defining and building consensus around a program or service intervention that would solve the problem. And finally, evaluating that change so that we can improve it and determine its effectiveness. And we have worked on a couple of problems, but in particular, I mentioned earlier that we finally have established urgent care as a mental health and substance use treatment intervention. About 4 years ago, the problem in Massachusetts of people waiting in emergency rooms to be admitted to hospitals was huge. It's actually gotten worse since then due to COVID. But people, it is true that in some of our hospitals, if you go to the hospital with chest pain, you may wait overnight before you're admitted to a bed if you need a bed. But if you go there with a psychiatric condition, you could be, depending on your needs and what part of the state you're in, waiting weeks or in rare cases months in the emergency room for access to care. It's the only health condition that experiences stays that are typically longer than 24 hours waiting for a bed. So we were talking about how to address this problem with experts in the field, and first and foremost with people who are patients or clients affected by this and their family members. And in talking to them about it, many people said, well, we just need to build more hospital beds, which was part of the solution. But we were looking at how do we really get upstream of this problem and try to help people before they get into a life-threatening crisis and need inpatient care. So we began talking about models of care from elsewhere in healthcare, and urgent care became an obvious one. And we worked not only doing research in the peer-reviewed literature about models that might be effective, but in visiting programs in other parts of the country that were doing this, and in pulling together the leading psychiatrists and other clinicians in the state, program providers, and policymakers to build consensus about a model in the Commonwealth for urgent care. Based on that consensus, the Secretary of Health and Human Services was willing to adopt it as a model of care in the roadmap for reform, and has since, as I said, designated more than 60 clinics around the state who will provide that service. They set a rate for the service. We did put language in legislation to support that change, and we worked on regulatory changes, all part of that cycle, all part of what we undertake to make change happen. I mentioned safe and affordable housing and services targeted to homeless people. This is a priority for us, because if we cannot take care of the people who have the worst outcomes from needing the mental health system and not getting what they need timely, then shame on us. And homelessness is one of those worst outcomes. Jail is another one. Obviously, trying to protect people from self-harm and suicide is another. So we focus a lot on that. We're very involved here in Middlesex County with the Sheriff of Middlesex County, Peter Katusian. You may know Sheriff Katusian. He was formerly the state senator for this area also. And Peter Katusian and I co-chair a commission that is going to build the first crisis resolution and respite center, where the police, rather than coming out to your 911 call and deciding they're going to take somebody off to jail for the night because it's quicker than taking them to a hospital, will take people to the restoration center. Similarly, an ambulance will be able to drop someone off who doesn't need inpatient care but needs immediate attention and a safe place to be at the restoration center. So right now, this is out to bid, as the Commonwealth says. The Commonwealth is in a procurement period, trying to get a provider to offer this service, but we expect to see this within the next year. So we're also focused about care across the lifespan, and I know my colleague is going to be talking from a clinical perspective, so I don't want to go into too much detail here. Just to point out that we're concerned about child and adolescent mental health, older adult behavioral health. We target various budget and policy and program initiatives to each of the age groups affected by these conditions. We work tirelessly to disseminate knowledge that will educate policymakers. How am I doing on time over here?
It's quite big. We
Okay.
have another few minutes before the
I will move along. COVID-19, I mean, the terrible thing about COVID-19 is it disrupted so many people's mental health and well-being. It drove the numbers of people needing care in a given year up into double digits. It left over 60% of children, the parents of over 60% of children and adolescents saying that their children's mental health had been disrupted. They were anxious and depressed and worse. And in the case of Massachusetts, just to take one statistic and one example, the number of girls showing up in emergency rooms who had either attempted suicide or had an active plan for suicide increased by 50% in 2021. It had a huge impact on children's and youth mental health and well-being. This statistic here, about 48% in 2020 of youth saying that they were feeling sad and hopeless for 2 weeks or longer. That number went up in 2021. So we have been looking very carefully, and the legislature really instructed that those of us in the stakeholder community look at the impacts of the COVID-19 pandemic on kids' mental health and make recommendations for change. So we actually led along with the Children's Mental Health Campaign, that policy research, and a report was issued, and in fact, the Executive Office of Health and Human Services and the Department of Mental Health have taken affirmative steps to implement the recommendations, which is expanding access to care, expanding investments in schools, etc. I mentioned before the workforce challenge. I'd like to say that our next speaker is from William James College, where they're doing incredible work to grow the workforce in mental health and behavioral health, and also to target the growth of a workforce with the cultural competence to meet the needs of minority populations. I'm sure we're going to hear more about that. The mental health education of students is vital, and helping students to understand their mental health, how to protect it, the factors that impact it, what to do if they are feeling depressed or anxious and need help, etc. These are critical things to be addressing. I mentioned the urgent care service, the new service. One of the things we're trying to do with that service having been implemented as of January of 2023 is to build partnerships between the community behavioral health centers who provide the urgent care and their local schools, so that schools become the preferred customer of the urgent care service. Right now, schools have, basically feel that they haven't got a choice when a kid is having a really difficult time and it's more than the school can handle. They'll call 911 and have the child taken to a hospital. Or in some cases, they'll call the police and have the child picked up and taken out of the school. This really allows the community behavioral health center to send a clinical team, including their local crisis intervention team, on site to the schools, and to disrupt that more negative outcome of putting a kid in an emergency room or putting a kid in a police car. So these partnerships are really important to forge, and we are working on that. We are online, so to increase awareness and also to increase access to care. So we work hard, and I'm not the one in my organization doing this. I'm fortunate to have really smart young people who understand social media, who are working to increase that presence online every day. And we partner with very, other people like ourselves, other people with shared interests, like our Children's Mental Health Campaign, with the CEO Alliance nationally, with housing advocates and whatever, to again make change happen. And to increase inclusion and ensure access to services, Massachusetts is blessed with a lot of services, but most people can't figure out how to access them. So a few years ago, we created something called Network of Care Massachusetts. It's a comprehensive and searchable online database of behavioral health and related social services. It's available in 133 languages, and it has an information hub for culturally responsive services and another information hub for COVID-19 resources. That involved a number of services. There are over 5,300 mental health, substance use, and related social services on that site. It's searchable by zip code, it's searchable by diagnosis, it's searchable by what's available in Belmont. It's searchable by program type. And it is now being used as the information system behind the behavioral health helpline that I told you. So when the operators, if you were to call in and say, I'd like to know where the outpatient clinics are in my community, the operator will be looking at the network of care database to figure that out. The other thing that's available on Network of Care, which is a library of over 30,000 curated articles and studies on behavioral health, and actually on all of them, so people can improve their health literacy. They can read about a condition. They can also read about the best treatments for that condition, or they can read about well-being and how to protect and preserve well-being. So I'll move on from there. So here are some ways to link to us and stay up to date with the things we're doing. If anybody needs anything, I think you have my name and contact information. and we're happy to be helpful to people in any way we can. Thank you.
Yeah. Now we are going for a Q&A. We're going to have 15 minutes of Q&A. And would you like to come and join us?
Yes.
Perfect. And then after the Q&A, we have a coffee. I know it's exhausting. Mental health. So, first of all, wow. Because when I contacted you, I actually didn't know that what Massachusetts Mental Health Awareness Association does is so similar what MHAI does or tries to do. I'm going to present that in few minutes, an hour or so. But I'm very surprised to find the similarity. Thus, I want to kickstart the Q&A with the following question. You were just talking about the role of professional organizations, and the data and the information was amazing. Yet, in a very simple terms, why do you think professional organizations are important in advancement of mental health awareness?
Well, I think they're important because they bring together a body of knowledge and a set of resources and hopefully voices that can help the broader public, but also targeted groups in positions of power and authority and who control resources to make change. And whether that is the Mental Health Association or the group of people who advocate as families of people who have these conditions, the National Alliance for Mental Illness, or a group called PAL, the Parent and Professional Advocacy League, who are the family members of children and youth with these conditions, whether it is the groups of people with lived experience who are very effective at communicating what they and their peers need, or whether it is the Mass Psychiatric Society, Mass Association of Social Workers, NASW, it's the National Association of Social Workers at the Massachusetts chapter. There's the Massachusetts Association of Psychologists. We have all these professional organizations. Everyone has a unique perspective, but I would say in Massachusetts, across all the stakeholder organizations, there is a unity in our point of view about what the needs of people are and what are the best approaches to meeting those needs. We don't have a group of stakeholders who are fighting with one another or disagreeing by and large with one another. There's a core set of agreements. Beyond that, people have their special interests and special sets of knowledge and skills and expertise that they deploy. Providers, in addition to the professional societies, the psychologists, the social workers, the nurses, the physicians, we also have two different organizations that represent the Massachusetts Association for Behavioral Health Care that represent the substance use and mental health service provider organizations. They're all have an important point of view, all work really hard to contribute to this effort to improve public awareness, to remove barriers in access to care, and to try to drive for more resources. The behavioral health field is underfunded as compared to other health fields. It's part of the reason why we have a workforce crisis. The reimbursement rates are too low from years of underinvestment. Why that underinvestment? Because of discrimination. Discrimination against the people who need the services and discrimination against the people who take care of them. So it's no surprise we have a crisis because finally the rates were so low, people working in these jobs can't really afford to pay off their education debt and raise families and find a place to live in an expensive city like Boston, and it all has come to a head. So we're finally addressing some of these problems, but we need these different organizations and their voices in the mix to make change happen.
Thank you. So, for the questions, please come to the microphone and ask your questions. Okay?
Thank you so much. It was very informative. So my question is about the COVID pandemic's influence. You said that you guys worked on a report and shared it with the stakeholders. So I guess I want you to expand on it a little bit, but specifically about why it happened. Meaning, is it the isolation, the disruption that led to the crisis, especially amongst the youth, or is it? I mean, they are related, I understand, but is it the overuse of social media, for instance? Because we also hear a lot about social media's influence, right? The mental health issues. So yeah, does it come? Is there any legislation? Are you trying to come up with policy recommendations about social media use? For instance, I know that there is discussions about possibly banning social media at schools, for instance.
There are some schools that have banned it.
Exactly. And on that note, and this is the last note, I love that you have this social media. It's a good thing because we do spread our words with social media, right? Like, what's it? So, but TikTok is not there.
Those things, it has a positive dimension and a negative dimension, right?
Yes, but the youth are mostly using TikTok, right? So especially, I think if for awareness reasons, anything that goes on TikTok will have more.
So I would like to say that I'm neither a clinician or an expert in social media, and I might prefer to defer to my colleague here to answer some of that. What I will say is that we published 2 reports related to the pandemic. At the very beginning of the pandemic in 2020, we published a report, and it's on our website, called Deaths of Despair. Now, deaths of despair is an economic term that is the phenomenon of an uptick in the number of deaths related to alcohol-related liver disease, suicide, or overdoses. And those tick up usually in difficult social and economic times. And we were predicting that the pandemic would create similar stresses. And we actually used data from the economic downturn between 2008 and 2014. I have a background, I got my doctorate at Brandeis, and you don't get out of that place without health economics these days. So my doctorate is in health economics. So I tend to like look at these economics issues. So the disruption, the economic disruption of COVID drove a lot of the problems that both adults and children had. And I'll explain in a minute about the kids because it doesn't seem maybe obvious on the surface. But people's employment was disrupted. Some people were able to go home and get on Zoom and never missed a paycheck. But not everybody. In fact, not most people. People had their schedules cut back. Sometimes they lost their work altogether if they were in the service industry, or if they had to, you know, the kind of work where you have to go on site where they were at constant physical risk. So they were working, but they were under threat daily of getting sick, maybe getting vulnerable members of their household sick. And this caused a lot of anxiety, depression, which is common when people lose work and lose economic stability, financial stability. That threatens housing. Housing stability is essential to sound mental health. People were losing their housing. They were losing food security was a problem. All of these things, and we were arguing at the very beginning, we don't just have to get more mental health care out there. We have to stabilize people's economic situation. We have to, and the government did that. Although I will say here in the United States, the government did that in a way that was different than some European countries. So in, you know, the Northern European countries, money was given directly to businesses so that they could keep people on the payroll even if they weren't coming to work. Interestingly enough, in the United States, we paid unemployment out. Now, the difference was about the same amount of money per capita was spent by both of our governments, let's say the Danish government and the US government. However, in those Northern European countries, people retained their identity as a worker. They retained their long-term benefits being associated with their companies or their government that they work for. Here, that was all disrupted. If you went on unemployment, you lost your relationship to your place of employment. You lost the long-term view of the benefits that come from that. So, I mean, I may be getting too much into the weeds here, but I really believe these economic policies have effects, in this case, negative effects. With kids, they live in the households where the adults were losing income and were housing insecure and food insecure. And they were having to try to go to school online, some of them in families that didn't even have access to the internet. And, you know, they were watching people around them die. So social media, yes, is it a problem? But I think kids were dealing with a lot of other problems as well.
But you gave the example
Excuse me.
suicide attempt from
Excuse
Rhode.
me, excuse
Yes.
me, if somebody, I'm sorry, but as a moderator, if you have a follow-up question, please come to the microphone and only ask questions from the microphone, okay? Thank you for understanding. Now, we have around 3 minutes before we go for a coffee break. So either somebody who has a question, come and ask the question, and then we will have a chance to ask Dr. Mauch a question later on. Thank you.
Thank you so much for being here. And listening to you speak, I mean, doing this work since the 1970s, wow. And so we're all here and we're hearing all of the work that you're doing and hearing you talk about being an agent of change. And that's really inspiring. And hearing that makes me think a two-part question is, how can we be an agent of change? We're all here, we're listening to you. How can we be an agent of change, and how can we be a voice of change for this issue?
Well, I mean, I think there are ways to do that depending on what your job is at the individual level in the organization you work for, in the way you interact with the people you take care of. But I also think coming together in groups and unifying your voice with the voices of others makes a bigger impact in some cases. I mean, one person can have a lot of impact. I'm not saying I want to say that. But I think if you want to make systemic change, you need multiple voices. Unless you have, like you're the commissioner of mental health and you can just say, we're going to do this, right? Then one person, actually, the Secretary of Human Services, we were fortunate to have a very, activist Secretary of Health and Human Services, Mary Lou Sutters. We have a new secretary. She'll be activist in her own way. But when Mary Lou was the secretary, and she had prior been the commissioner of mental health in the Commonwealth, she was dedicated to making change happen every day. Now, change doesn't happen overnight, but they were working at it constantly. And, but for those of us who are in different positions, we need to align ourselves with others and unify our voices to elevate them and elevate the message about the change that needs to happen. And there are a lot of different levers of change. Sometimes, like this urgent care thing, we needed to have legislation that made this, that said this will be a service in the Commonwealth and defined it. We needed to have regulations that changed how things got licensed to create that program category. We needed to have a rate set. The reimbursement rate for the service had to be established. And then finally, they had to have a process of selecting, basically determining which organizations would meet the criteria to be eligible to provide the service. There are so many moving parts in that, but we all kind of stuck with it every step of the way and saw it happen. It took several years. Now, I would argue that there are faster ways to get things done. As I say, if the person in charge decides they're just going to make that change happen, and they have control over the regulations, they have control over the budget, they have control over the process of setting reimbursement rates. Somebody like the Secretary of Human Services can make change happen faster than a group of external people.
Just one follow-up question. What's one tangible ask that you have of us sitting here today that we could do to make change happen today?
I think it's to elevate your voices, to talk about who the people are that need, to bring the humanity forward of the people who need care and the people who care for those individuals, and really help to explain to people why it's important to invest in their mental health and well-being. Thank you.
Thank you, Dr. Mauch, and for amazing presentation and for answering the questions. If you have any questions to Dr. Mauch, you're more than welcome. Stick around and ask your questions. Now we're going for a maximum 10 minutes coffee break, and then we will be back